Hello and welcome to our program entitled Beyond Borders in Relapsed and Refractory Multiple Myeloma, Optimizing BCMA bispecific and CD38-based combination therapy. My name is Dr. Joseph McHale. I'm a professor at the Translational Genomics Research Institute. You can see my disclosures here on the screen, and this is an educational activity that is supported by an educational grant from Johnson & Johnson. Lastly, the learning objectives for today's programs are displayed on the screen, and you can see here that we are going to be diving in deep to bispecific antibodies and their combinations, and all of the other great options that we now have in relapsed and refractory multiple myeloma. So let's get going. Myeloma has really evolved dramatically over the last decade. When we look at where we were and where we are now in terms of what we do in frontline therapy and what we do in relapse therapy, it's really changed the way we treat patients with multiple myeloma. As you can see here, of course, we have multiple drug classes. We have our immunomodulatory drugs, proteasome inhibitors, steroids, of course, monoclonal antibodies, and traditional alkylating agents, as well as some others that we'll be mentioning at different points during the program. And these agents now, we've learned that if we can combine multiple classes together, we're going to have better outcomes in multiple myeloma. So we've reached a point now where we're typically using a proteasome inhibitor, an immunomodulatory drug, as well as a monoclonal antibody with a little bit of steroids, typically dexamethasone, of course, as a quadruplet combination in the vast majority of our frontline patients with multiple myeloma. The reality is, sadly, as we know, the vast majority of our patients will relapse with the disease. But now we have many more options than just going back to those same classes or a second transplant. We now can look at things like CAR T-cell therapy, antibody-drug conjugates, bispecific antibodies, and even combinations of these drugs together. So we're going to be exploring that a little bit more, because not only are we using those agents in late relapse where they were first approved, we're seeing them now move earlier and earlier. And as recently as just a few months ago, we now have access to teclistamab and daratumumab as early as first relapse multiple myeloma. Well, these bispecific antibodies, how do they work? I suspect that you're familiar with them, but just as a quick review, they're called bispecific antibodies, of course, because they have two arms. One arm hooks onto the myeloma cell, typically through the BCMA target that we're going to be focusing in on, although we'll have some discussion about one of the bispecific antibodies that targets a different antigen on the myeloma cell, GPRC5D. And the second arm reaches out and hooks onto a T cell, typically through the CD3 antigen that's on the T cell, to engage that T cell to destroy it. And in doing so, multiple things happen. Obviously, T cell activity is very complex. There's direct activity. We know there are other cytokines that are released. It can engage more of the immune system to help destroy that cell. And although most of our focus today will be in BCMA targeting, as I've mentioned, or B cell maturation antigen targeting, there are other antigens. The BCMA target is very important because it's really quite a resilient target. In fact, we're learning a lot more. We won't have as much time to talk about it today, but we are learning a lot more about leveraging that target more than once. So where patients can receive at one point a CAR T, another point an antibody-drug conjugate, another point a bispecific antibody as we're focusing in on today. So it really is an important target. But there are two other targets that I want to make reference to. The second is GPRC5D. This is also heavily expressed on multiple myeloma cells, and we can now leverage it with the use of talquetamab, which is already FDA approved, and there are others in development to be able to target GPRC5D. Thirdly, we also have FcRH5. Now, we don't yet have an FDA-approved agent for this, but cevostamab is in development and will be likely available to us in the near future, which gives us yet another way to target the cell. Even though these targets are quite resilient, eventually there can be target resistance, and so having the opportunity to target the disease in a different way is really important. Lastly, I'll note that we have multiple agents that target BCMA. We already have FDA-approved 3 of them, teclistamab, elranatamab, and linvoseltamab, but there are several other in development like etentamig and others that we're going to be hearing a little bit about today, but also will be obviously great discussions in future programs. So let's talk a little bit about how teclistamab has made its way from late relapse to early relapse. One of the most influential studies we have seen has been the MajesTEC-3 study. This was a study where patients with 1 to 3 prior lines of therapy were treated with teclistamab, the bispecific antibody, along with daratumumab. So these were primarily patients that had not seen daratumumab before. That combination, when compared to a standard triplet that we would use in early relapse. And this was particularly important because now you have patients that are not CD38 refractory, of course, have not seen BCMA, but it was really remarkable. At the 3-year mark, we had almost 83.4% of patients still in remission in the Tec-Dara arm, where it was really only 30% of patients in the comparator arm. This was really a dramatic, eye-opening experience for a lot of us because we had been using bispecifics in much later relapse and didn't have this kind of prolonged PFS, but it speaks to the power of being able to use a bispecific in earlier relapse. Furthermore, over half of these patients, nearly 60% of them, had achieved MRD negativity. There were, of course, adverse events as to be expected. In particular, I'd just like to highlight the fact that there were significant infections here. In fact, the trial at one point was stopped when several patients had very serious infections, and more careful protocols, including mandating IVIG use and more careful antibiotic prophylaxis was used. And thankfully, we saw a dramatic drop-off in the serious infections and even death by infection. So there were 54% of patients that had grade 3 infections or greater in the intervention arm versus 43% in the control arm. And sadly, 4.6% of patients did die from their infection. The second study that more recently was presented was similar in its design, where this time we take the bispecific antibody teclistamab again, but without a partner, just monotherapy, and compare it to what we would traditionally use in relapse with PVD, so pomalidomide, bortezomib dex, or just carfilzomib dex. I think this study is particularly important. Another large phase 3 trial like MajesTEC-9, like MajesTEC-3, MajesTEC-9 is a phase 3 trial, but also because now there is so much CD38 exposure in early line therapy and in frontline therapy, a lot of our patients are already exposed to CD38, so they would not be eligible for the MajesTEC-3 regimen. So being able to give the drug monotherapy was important. This group of patients was a little bit more heavily pretreated, but again, remarkable difference in PFS. So at 18 months, 70% of patients were still in remission in the Tec alone arm, whereas only 27% in the comparator arm with the PVD or KD. So this was, again, very dramatic. We saw almost 40% of patients achieve MRD negativity versus only 7% in the control arm. So I think we're painting a picture here of how much better these therapies can be when compared to traditional triplets, but also the feasibility of delivering them and the longevity of the benefit that we see from them. So really, teclistamab monotherapy, although it's not formally yet indicated in this area as monotherapy, is very likely going to influence the early relapse phase. The third, and yet another large phase 3 trial, now used one of the other bispecific antibodies, talquetamab, that I mentioned, that targets GPRC5D. And this was a 3-arm study, the Monumental-3 study. So in Monumental-3, patients were either given talquetamab, daratumumab with pomalidomide and dex, or just talquetamab, daratumumab and dex versus the comparator arm of daratumumab, pomalidomide, and dexamethasone. So it was adding tal to darapom or even just giving tal-dara as the 3 arms of the study. And again, remarkable outcomes here. So the 2-year progression-free survival for the tal-darapom arm and the tal-dara arm were actually really quite similar at 81 and 78%, but the DPD arm was only 51%. So again, it speaks to, I think, the power of the bispecific antibody now using a different bispecific antibody with a different target. Now, of course, we see different effects from this. The MRD negativity rate, by the way, was over 50% in the tal-darapom arm. We saw less infections, as we typically do with tal versus teclistamab, but there were other effects. We know that there were some neurological effects, that there were effects on taste and weight loss, although that did stabilize over time. This is a drug that, again, we're becoming more familiar with its use over time to make it more manageable for our patients. But again, the conclusion is the same. This time, the combination of talquetamab with either daratumumab and POM or just with daratumumab was considerably better than what we saw with triplets. And then lastly, from these bispecific antibodies, there was a trial that we've had updated now and published, was adding teclistamab and talquetamab together. This is not a large phase 3 trial, but this was a particularly important trial, the redirect trial, because it was selected explicitly for patients with higher risk disease, and particularly many of these patients that had extramedullary disease. So this is, as we know, as if you'd care for patients, is a very challenging area to treat. And this is a very challenging disease at this stage, but yet this combination together, we're leveraging both targets of BCMA and GPRC5D, was really quite remarkable with an 80% response rate. We would have expected a dramatically less response in patients with this more heavily pretreated therapies. And so we saw outcomes similar to what we've seen with these agents in monotherapy, maybe even a little less because they were given less frequently. So as we look to the future of other combinations, I've already mentioned that we combined talquetamab with daratumumab, but now there are further therapies of adding the pomalidomide to the Tec-Dara combination that we discussed. And there's yet a new kid on the block, another new agent emerging, etentamig, which is another bispecific antibody that targets BCMA that from the start actually is given only once monthly, and it's also being combined with daratumumab and dexamethasone. Bispecific antibodies, of course, are not the only way that we can leverage BCMA in the relapse setting. We have now reintroduced the agent belantamab mafodotin as an antibody-drug conjugate. So as you remember, this is an antibody that targets BCMA, but attached to the drug is that toxin mafodotin that can be brought into the cell and help destroy the cell. And this was guided by two very important clinical trials, the first of which is the DREAM-7 study. So this is where we gave belantamab mafodotin plus bortezomib and dex versus giving daratumumab, bortezomib, and dexamethasone. So really a triplet versus a triplet study, which is not something we typically see very often. And it was really remarkable how well the belantamab mafodotin arm did. And not only did it significantly improve progression-free survival when compared to the daratumumab, bortezomib, and dex combination, the absolute benefit was remarkable in my estimation at 36 months. So we have 3 years of progression-free survival by using this combination of Bela, as we sometimes call it, the belantamab mafodotin, plus bortezomib and dexamethasone. So patients got into a deeper response, much more durable than when daratumumab was used. Similarly, in the DREAM-8 study, we had another triplet versus triplet study. Here, it's the belantamab added to pomalidomide and dex versus bortezomib, pomalidomide, and dex. And again, we see a dramatic difference, almost again reaching a PFS of 3 years by being 32 months. And again, we saw that this was very feasible to combine in this combination with pomalidomide. Now, of course, both of these studies did have issues around eye-related side effects, where roughly 2/3 of patients do have some change in visual acuity, and approximately half of patients develop dry eyes. And we've learned a lot since these studies were done that if we give the drug less frequently, we can see considerably less toxicity, and we'll discuss that a little bit more as we go forward. Well, we can't have a discussion about BCMA targeting in relapsed myeloma without talking about CAR T-cell therapy. So let's talk for a moment about the CARTITUDE-4 trial, which led to the approval of cilta-cel in patients with early relapse. So the CARTITUDE-4 trial was really groundbreaking in many respects, and patients as early as first relapse were given this in a phase 3 manner, single infusion of cilta-cel versus the standard of care, which in this case was pomalidomide, bortezomib, dex, or daratumumab, pomalidomide, dex, two of the triplets that we more routinely use in patients who are len refractory with 1 to 3 prior lines of therapy. And the results were dramatic. We still have not seen the progression-free survival met. It's likely going to exceed 4 years versus approximately 1 year with the combinations. This dramatic difference led to its approval, and now we have it available to us. And I always challenge us to think, should we be thinking about a BCMA-targeted therapy at every patient who has first relapse, whether it's CAR T, whether it's a bispecific, or whether it's an antibody-drug conjugate? Similarly, we had the other CAR T-cell therapy approved in earlier line therapy through the KarMMa-3 trial. This is, of course, ide-cel, and in a similar way, although these patients had at least 2 prior lines of therapy, and so its approval is in patients with at least 2 prior lines of therapy, we again saw the single agent infusion of ide-cel versus a triplet combination demonstrate a dramatic improvement, where here the progression-free survival is about 14 months versus only 4 months. So again, this is later line disease, but again, the difference between the two really quite dramatic and really quite tolerable. So you might say to me, Joe, how do you decide between all of these therapies? And it's an embarrassment of choice in some ways, or embarrassment of riches, as we say, because I love having choice for our patients. It's become where we don't just have one or two. Often we have multiple choices. And so this really comes down to multiple different ways of thinking about when would I introduce a bispecific versus CAR T versus an antibody-drug conjugate. All three have a place. All three are significant and important, but we can think about different ways that would point us in one direction or another. Often in patients where their disease is growing quite rapidly and you want to get to therapy right away, that tends to favor shying away from a CAR T-cell therapy and going to a bispecific antibody or potentially an antibody-drug conjugate. Because typically with CAR T, we want the disease to be better controlled. We want to give good holding and bridging therapy because we know that reduces toxicity and improves the outcome. So often when patients have high burden of disease, extramedullary disease, and so on, we may want to be able to go to a bispecific antibody. Also, the bispecific antibodies allow us to switch targets by going from BCMA to GPRC5D or vice versa, whereas the other agents target exclusively BCMA. And then they're just practical things that are so important. How easily is someone going to get to a CAR T center and go through the whole CAR T process? Do they have a care partner who's going to be able to help them through it? There's their geographical issues. There's their pragmatic issues. Bispecific antibodies often now could be given directly into the community. Antibody-drug conjugates obviously can clearly be done, but there does require some monitoring throughout. So there is no one size fits all here. It really is tailored to the individual. And as we think about the biology of that also helps guide our treatment. And lots of detail here, but what's very important are a few elements of the biology. Number one is the T cell itself. We know that when we give CAR T-cell therapy, it's a one-time use of T-cells that actually lasts several months, but that's an engagement that comes to an end. Whereas with bispecific antibodies, you have constant T-cell engagement. And so we know that we can exhaust our T-cells, and it's important to have, if you will, therapies in between that gives those T-cells a rest. Secondly, we have things related to the tumor biology, specifically it's the targets, all these targets that we have. Most patients express both BCMA and GPRC5D, but with time, that target can be lost. And then, of course, thirdly, we know there's a lot to do with the environment, the microenvironment of the disease itself, how it interacts with the immune system, what other therapies it's had or it has been available to it before. Those are features that can significantly influence the way we decide on therapy and make a treatment decision for our patients. But of course, it's always critical to engage the patient. This should never be a one-way discussion. And I know sometimes people phase out a little bit when we talk about this, but I have more than ever do I believe in the concept of shared decision-making. Now that we have all of this choice, now that it really is influenced by a patient's preferences, by what they want to have, it's important. I can't offer the best for my patient if I don't know what is the best in their estimation. Yes, progression-free survival and response matters. Yes, of course, toxicity matters. But we want to have that conversation with the patient because sometimes we're surprised by what patients may wish and what they may not wish for. And now that we have this choice, making sure that we lay out the options and then match them to the patient's preferences is really the heart of shared decision making. So as I try to bring this all together of what we've been discussing so far relating to relapsed therapy in multiple myeloma, let me remind us that there is no simple algorithm anymore with multiple myeloma. Every patient is unique. Every patient should be looked at uniquely, and we want to sequence and select therapies that are best for our patients. But a few key summary points that we can share together. Number one, BCMA-directed therapies have really changed the landscape of relapsed and refractory multiple myeloma. We have CAR T-cell therapy. We have bispecific antibodies. We have antibody-drug conjugates now. They have all demonstrated dramatic response rates and prolonged response rates, especially when compared to the historical triplets. I'm not saying that there are no patients that would benefit from a triplet, but we're really not using those as much anymore, especially in that early relapse. You should really be asking yourself, why am I not delivering a BCMA-directed therapy at first relapse if that is not on the table for discussion? Point number 2, we now see amazing phase 3 data that has pointed us to multiple combinations. Approved already is teclistamab and daratumumab in early relapse. We have seen really outstanding results from it, and we know that we have that opportunity. Also in early relapse, we have CAR T-cell therapies, both with ide-cel and cilta-cel, and indeed with the antibody-drug conjugate belantamab mafodotin, specifically in the US in combination with bortezomib and dexamethasone. My third major point is that treatment decisions are not simple. There isn't a simple algorithm. We look at elements of the disease, elements of the treatment, and then, of course, patient preference and factors, and put those together in a matrix to decide what is best for this specific patient. Thankfully, we know, as I noted briefly earlier, that we can sequence most of these therapies in almost any combination. It's generally preferred to use a CAR T prior to a bispecific antibody, but we know there are ways to sequence each of these therapies. And so we're not, if you will, burning bridges for later. We don't want to save the best for last. We want to give the best therapy to our patients at any given time. Major point number 4 is that we are looking to more and more combinations, whereas bispecific antibodies, teclistamab, elranatamab, linvoseltamab, talquetamab have all been approved initially as monotherapy. Now, of course, we have teclistamab and daratumumab in early relapse, but we are moving towards combination of all of these agents and others. Specifically, we've seen several of them combined with daratumumab, the talquetamab and daratumumab, teclistamab and daratumumab, being studied, others with daratumumab in the future. So that is leveraging that antibody benefit together. And then lastly, I think we are, even as monotherapy, going to see these agents come into earlier lines of therapy, specifically because of the Majestic 9 combination, where we saw monotherapy of teclistamab performing superior to triplets, that we're going to see that combination used earlier in the disease course. And although it's, of course, hard to compare across trials, the clear theme is there. We are seeing a significant improvement in these therapies when compared to the triplets that we've had before. I know that's a lot to take in, and it's amazing to think that a lot more is coming in the world of bispecific antibodies and other choices in early relapse, but more choice is only going to mean better choices for our patients, better options in the long term to improve both their quantity of life and quality.